Hello everyone and welcome to today's webinar, Applications of Procalcitonin-Aided Decision-Making for Antibiotic Stewardship in Emergency Care. I am Jennifer Woods of LabRoots and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Thermo Fisher Scientific. To learn more, visit thermofisher.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have any trouble seeing or hearing the presentation. This presentation is educational and thus offers continuing education credits. Please follow the process to obtain your credits by clicking on the Continuing Education Credits window. I'd like to now welcome our speaker, Larissa May, Professor of Emergency Medicine and Director of Emergency Department and Outpatient Antibiotic Stewardship at the University of California, Davis. Larissa, you may now begin your presentation.
Great, thank you. Okay, can you see my slides?
Yes, you can.
Wonderful. Well, I'm delighted to be here and thank you all for attending. We're going to be talking about applications of procalcitonin to improving antibiotic stewardship in emergency care. The objectives for our talk today are to discuss procalcitonin as a biomarker to help distinguish viral versus bacterial infection, to review some of the literature supporting the role of PCT in promoting antimicrobial stewardship and patient outcomes in various clinical settings, particularly focused on the ED, and to discuss some opportunities and challenges of implementing PCT in emergency care settings. These are my disclosures. So let's focus first on antimicrobial stewardship. I'm sure most of you are familiar with the growing problem and public health threat of antimicrobial resistance. A lot of this is fueled by inappropriate prescribing of antibiotics in a variety of healthcare settings. Actually, the vast majority of prescribing is for upper respiratory tract infections that occur in the outpatient setting. And yet we also know that antimicrobial resistance causes increased morbidity, mortality, and healthcare cost. And therefore, there's a great focus on limiting antimicrobial use that's inappropriate in the inpatient setting as well. It's also a patient safety issue, as antibiotics that are unnecessary can be associated with adverse events, the most pressing of which is the increasing incidence of Clostridioides difficile infection. So what about antibiotic stewardship in the emergency department? This really is an opportunity for us to focus on the quality of care. So what is antibiotic stewardship? It really is the optimization of antibiotics. So broad-spectrum antibiotics are often appropriate in our setting. For example, they are key to the Surviving Sepsis campaign, and I'll show some data about how antimicrobial use and starting it early can actually improve patient outcomes. We're also measured on some of these metrics, and so there are incentives on hospitals to comply with them. And finally, clinical pathways will often include decision-making tools that will help guide antimicrobial choices. What we do know from our setting in the emergency department is that the choice that we make as empiric therapy in the ED is often continued into the inpatient setting. What is the role of rapid diagnostics and biomarkers in acute infection? I'm going to discuss some of the opportunities and challenges to using these in acute care, the application of potential testing strategies, and really the emphasis on appropriate integration into the clinical environment, including assessment of workflows in various clinical settings, the need to align with clinical operations and obtain leadership support, and finally, really integrating those tools into antimicrobial stewardship and patient safety endeavors. There are multiple approaches to stewardship and improvement of patient safety. So until recently, many hospitals did not engage or include ED clinicians in their existing antimicrobial stewardship planning committees. However, that is rapidly changing. Appropriate stewardship requires multidisciplinary collaboration, and some strategies might include education, although we know that's not sufficient for maintaining change. Guidelines and clinical pathways can also be developed that can help guide clinicians to doing the right thing. And then finally, other strategies such as peer comparisons and audit and feedback can also provide important input into changing practice. With the advent of the electronic health record, we're moving more towards the direction of clinical decision support that can also incorporate some of these tools. And in the ED, we'll focus on care transitions, for example, patients being discharged to the hospital or returning to long-term care facilities or skilled nursing facilities. And then I highlight here rapid diagnostics and biomarkers that we'll be spending the rest of our time talking about, as it is a cornerstone of the IDSA strategy to combating antimicrobial resistance. We do have some current limitations in terms of infectious disease diagnosis, and that is mainly that our clinical judgment in the emergency department is often insensitive, and we often do not have diagnostic technology available in real time, or that technology is not specific or sensitive enough to provide quick and accurate data. Therefore, we have to employ a variety of strategies to improving antibiotic selection. Ultimately, what happens, though, is this leads to a conservative management approach where patients will get antibiotics that are often more broad spectrum than necessary. The benefits, of course, are offset by the cost of treatment and potential complications from unnecessary treatment or overtreatment. But what does this mean in the real world? What it means in terms of diagnostics is there's a gap in translating promising technologies. So we really need to look at feasibility, including those workflow assessments I talked about. And also, knowing that I'm talking probably mainly to a microbiology audience, we really need to redefine what rapid means. So testing and stewardship starts in the emergency department. However, our definition of a rapid test is something that returns in real time rather than an 8-hour test. And that can really be linked to improved patient outcomes. But implementation is key. For example, if we're going to implement a biomarker that could potentially change practice in reducing inappropriate antibiotic therapy, then we need that test to be implemented in such a way that it fits with our workflow and returns in real time rather than batch testing. The focus also is often on high-yield settings where the use would have had the greatest impact on outcomes. So, for example, for procalcitonin, in our ED, we frequently look at febrile infants and adults with sepsis. So I'm going to talk a little bit about sepsis because it is such an important concern and leads to such mortality in the United States. So there's an early detection benefit for sepsis. If we detect sepsis early on in the course of the patient's illness, the chances for survival improved. And really that has to do with starting appropriate empiric antibiotic therapy as quickly as possible. And so you can see the survival rate here really drops as time goes on and we miss this diagnosis. There's some other gaps in diagnostics in sepsis. So again, here at the top graph, you see the time to appropriate treatment versus survival. And so that's really appropriate starting of antimicrobial therapy. And you can see waiting more than 24 hours results in less than a 5% chance of survival. The immune system also plays an important role in when the deaths from sepsis occur. So early on, for example, in a healthy individual with meningococcemia with a hyperimmune response, you can see many of the deaths are going to be early. Whereas in elderly patients who might have some chronic comorbidities and a more localized infection, you can see that the deaths may occur later. And then finally, in patients that may have diabetes and some other comorbidities who have pneumonia, the deaths tend to occur late. However, starting antimicrobials is really a balancing act. So on the one hand, we have overuse of unnecessary antimicrobials that lead to downstream individual and community antimicrobial resistance, the incidence of Clostridioides difficile, and other toxicities and adverse outcomes such as anaphylaxis, and other minor complaints such as diarrhea or yeast infections. And then we have to balance that with the correct initial choice of empiric antibiotics, because we know that improves patient outcomes and reduces deaths. So here we see an antimicrobial spectrum of activity. When we look at an infected patient, there's a range of pathogens that can cause these infections, and we really have to think about empiric versus definitive therapy. So looking at the baseline, we're trying to figure out what the source of infection is in a more syndromic approach, what types of pathogens might be causing the infection, and looking at community-acquired versus healthcare-associated infection. Typically, we want to start early broad-spectrum empirical therapy for patients with sepsis within an hour. But really, as you can see here, with the diagnostic tools we have, we're very limited in terms of what options we have to make the right decision. So here we're talking about gram stains. The cultures aren't going to come back for at least 24 hours, perhaps earlier in some cases of sepsis. We have to supplement this with other laboratory tests and imaging. And really, it's not until 24 to 48 hours where de-escalation may be possible based on the results of cultures and susceptibility testing, especially if we're adding some of these rapid tests to identify organisms and to identify their susceptibilities. So really, this results in a pretty significant delay. As I mentioned, there are also some challenges with implementation, and there have been many studies that have failed to show the desired impact on clinical care and outcomes. So while we may have an ideal test, if it's not implemented in line with workflow or the clinicians don't trust the results of the test, then we've got a problem in terms of actually improving outcomes. We all practice in complex healthcare environments. Healthcare is dynamic, and so there are many changes ongoing on a regular basis. And so the major gap is still often integration of the clinical microbiology and clinical lab versus healthcare setting workflows. And I'll touch on this a little bit later, but I think there's also often, at the development and implementation of these tests, a failure to consider physician behavior and how we make decisions. There are also in emergency departments some particular challenges to workflow. Most of you who have been in an emergency department, either as a patient with a family member or perhaps just walking through, can see how much crowding and boarding is going on while patients are waiting to be admitted to the hospital. In the more urgent care areas, there's a lot of patient turnover, and therefore clinicians have to make really quick decisions with limited information, including access to diagnostic tests. We typically practice with a mix of providers in a shift-based scheduling format, which means there's a loss of continuity of care, and sometimes it's hard to reach particular clinicians after they've left their shift. And we also have to be comfortable with a certain amount of diagnostic uncertainty, but the reality is that diagnostic uncertainty, even in the emergency department, drives a lot of antibiotic prescribing. There's also the concern for healthcare access and poor outcomes. No one wants to be the subject of a morbidity and mortality report or peer review. Many of our patients, as we are a safety net for vulnerable populations, are not able to follow up for a variety of reasons. And so that's a concern also, and sometimes the thought is if we give the patient an antibiotic, they may do better. In reality, we typically don't see the adverse events that occur downstream. And then, of course, patient satisfaction is a big driver of antimicrobial prescribing. We've actually done some work in this area, looking at surveys and in-depth interviews across 8 sites in the United States with a variety of settings, and really these were the themes that we identified that might drive some of this clinical decision-making around antibiotic use. So, as I mentioned, resource and environmental factors, that really includes those issues of boarding, but also the availability of rapid diagnostic tests, access and quality of care received outside the emergency department, and believe it or not, with this patient satisfaction issue still being the major concern, even in emergency department settings, the patient-provider relationship does drive a bit of this. There is also what I call clinical inertia, which is basically habit, is just doing what we've always done. And then in sites that had local knowledge generation or quality improvement initiatives around antimicrobial prescribing, those settings, the clinicians seem to be a little bit more comfortable holding off on antibiotics when they weren't necessary, etc. I think one of the main strategies people always want to use is clinician education. So how does this work with diagnostics? Really, I think educational strategies, while important, have limited effectiveness because it's hard to reach all the different clinicians that need to be involved. You really need to have some tailored educational messaging. We've done multidisciplinary grand rounds, engaged thought leaders from the specialty or setting, but without ongoing oversight, this is really unlikely to lead to enduring changes. And we know how overwhelmed we all are now with Zoom and email. There are also the perceptions of what rapid diagnostic tests can do in the emergency department. Because we're such a risk-averse setting, I think most clinicians really prefer high sensitivity and specificity for all conditions, but particularly for high-risk conditions. Also, if we're thinking about turnaround times, especially for point-of-care testing, we really like that to be less than 30 minutes for most conditions, perhaps a little bit less important for patients being admitted to the hospital. And the test should be simple to interpret. The other questions clinicians may ask is if there's a benefit to testing versus simple empiric treatment. So sometimes it's easier just to send the patient out on an antibiotic rather than send a test. Also, sample prep and training can be an issue, particularly for point-of-care testing, and space is always a consideration as we are always looking for more space in the emergency department. Testing strategies should fit into the ED workflow and how we see patients. And then there's some major gaps where we really don't have great diagnostic tests, including UTI. And for other conditions, simply focusing on molecular, again, not taking into account the host response, can also be a limitation. So let's talk a little bit about procalcitonin. So this is a statement by some work that was done by Schuetz et al. Back in 2018, but essentially from a meta-analysis, for patients with varying types and severity of acute respiratory tract infection, using PCT to guide decisions about antibiotics is associated with lower rates of antibiotic exposure, antibiotic-related adverse events, and mortality. So let's talk just a little bit from a clinician standpoint. What is PCT? So it's a simple blood test that's specific for bacterial infection, and we find that in healthy people, PCT concentrations tend to be very low, below 0.05 nanograms per milliliter. Concentrations exceeding that threshold can be interpreted as abnormal. And during severe bacterial infections, including sepsis, those blood levels rise very rapidly. And typically, there's no elevation from viral infections. So here we have highly specific induction. This biomarker is produced in all tissues and systemic infections. And you can see here the tissues that produce calcitonin in healthy individuals. And then on the right side, you see the tissues, for example, in sepsis, that produce that. And so PCT can detect sources of production in systemic bacterial infections. So basically, PCT ends up being produced and released into circulation from the entire body. Kinetics of PCT are also interesting and very relevant for identifying bacterial infection early. So you see here, this is a graph showing time on the x-axis, and on the y-axis you see the PCT plasma concentration. And typically what happens is PCT will rise about 3 to 6 hours after a bacterial infection and peaks at about 12 to 24 hours. It has an approximate 24-hour half-life, and if the infection is adequately treated, those levels will start to come down. So many institutions, including my own, in the intensive care unit may use procalcitonin over time to de-escalate antibiotic therapy. There are some non-bacterial causes of procalcitonin elevation. Particularly, we have seen this in our own setting as we have a burn unit. Multiple trauma or severe burns or major surgery can lead to elevations. Prolonged circulatory failure, and also newborns under the age of 2 days because they have a physiologic peak in PCT. There are also other non-bacterial stimuli, certain medications or certain cytokines, anti-lymphocyte globulins that lead to pro-inflammatory states that can cause elevations in PCT, certain cancers that you can see here, and then malaria and certain fungal infections. Also, patients who have renal failure, particularly in the later stages of CKD, such as stage 4 and 5 and end-stage renal disease, will have slightly higher baselines. So how does one interpret PCT? Here you can see that in the healthy individual, again, we expect a very low level of PCT. And then as that bacterial infection becomes local and then further devolves into sepsis, you can see here that the PCT elevations will continue. So this helps determine both severity of illness and adequacy of source control. Here are some comparisons of available clinical biomarkers. We can think about the simplest one that's available from the CBC, which is a white blood cell count. It's not particularly specific. In fact, in the emergency department, so many patients seem to have stress responses, and so we see our trauma patients and other patients that will have elevated white counts without necessarily having an infection. But the sensitivity for inflammation can be pretty high. So the advantages of a white counter, it's simple and inexpensive. The disadvantage is it's not particularly sensitive, it's not specific for bacterial infection, and really is just a marker of inflammation. What about CRP or C-reactive protein? This is a little bit more specific for bacterial infection, a little less sensitive than the white blood cell count. It too is inexpensive and moderately specific, But again, it's got a slow induction, so the peak takes more than 24 hours, and there's no correlation with severity. We often test for lactate, particularly in the United States, for patients with sepsis. Again, really not very specific or sensitive. Again, it's inexpensive. It can be a reliable marker of perfusion, and it can predict a bad outcome. But really, the patient needs to be in at least occult sepsis for it to be elevated, and has very poor specificity for bacterial infection that doesn't lead to sepsis. So procalcitonin, the advantages here are is it's much more specific for bacterial infection. It has favorable kinetics. Again, that rise in half-life can correlate with severity of illness, and it can help guide antibiotic use, and you can sort of monitor the levels over time. There is, however, a need for education. There's a need for lab instrumentation, and it is more expensive than white count CRP and lactate. I show this slide just to highlight that clinicians are often very concerned about sensitivity and specificity, but what we really want is a negative predictive value. And of course, that's going to depend on the prevalence of the bacterial infection in the population that you're looking at. However, procalcitonin levels can be used as a rapid tool to rule out bacteremia, given the high number of false positive blood cultures and the time it takes to detect bacterial infection with a blood culture. This is a study that was published in JAMA in 2009, the ProHOS study. It was a multi-center non-inferiority trial that was in 6 tertiary care EDs in Switzerland. And they looked at approximately 1,400 patients. And what they looked at was lower respiratory tract infections. They looked at antibiotic with use with a PCT algorithm versus the standard of care, and really had similar outcomes with no change in adverse events. And what they were able to show was a decreased duration of antibiotic use in these patients, not insignificant, from 8.7 to 5.7 days. Here's another meta-analysis looking at procalcitonin use in 11 trials comprising 4,000 plus patients for lower respiratory tract infection. And the PCT-guided patients compared to the usual care had lower odds of antibiotic initiation and a shorter mean antibiotic use. There was no adverse impact on mortality or length of stay. That's actually a good thing. You want to show that there's not an increase in adverse events from using these strategies. In the intensive care unit, a meta-analysis of RCTs in adults with sepsis showed that PCT-guided patients did have shorter antibiotic duration compared with controls, about slightly less than a day, but not insignificant for ICU patients. And procalcitonin use, again, had no adverse impact on mortality. Finally, there was a patient-level randomized control trial of hospitalized patients with lower respiratory tract infection from the ED in 14 U.S. hospitals. And I'm going to show this study just to show that sometimes, even though you have a good test, the failure of implementation may lead to less than desirable outcomes. So in this case, they randomized patients to usual care versus clinical guidance for the role of PCT with an algorithm, and then they didn't find any significant differences in antibiotic days between the two groups. So why is that? Well, a lot of the sites were not particularly comfortable with this algorithm, and so the education piece was a challenge. There were also some challenges with interpreting the algorithm and their assays with different cutoffs, and the basis of calculating sensitivity and specificity of PCT levels as a surrogate marker for bacterial infection really, we need better diagnostic tests for lower respiratory tract infection. And typically these patients were of the sickest, so they were patients that were in the ED that had community-acquired pneumonia that were being admitted to the hospital. So the clinician had already made the decision that this patient needed an antibiotic. And so in this case, the PCT may not have swayed them in terms of delaying starting those antibiotics, although the results of not having any impact on duration were also a little bit surprising. So why might this be? Perhaps some of you have read this book, Thinking Fast and Slow. I think it really highlights how an emergency clinician thinks. But really, we have two distinct cognitive systems. We have a more automatic system and a more reflective system. So people like to think that clinicians are deliberate and rational and reflective when they're making clinical decisions. However, in reality, because we're humans and we try to save our brain space and energy, a lot of decisions are actually automatic. So they're uncontrolled, effortless. based on associations, they're quick, and they may also be experience-based, and they're not conscious. So those are the ones that we really try to target to guide clinicians or nudge clinicians to making better decisions. So what's the solution to this problem of implementation? Well, at least in the research realm, implementation science-based approaches that are based on the principles of behavioral economics can improve both test ordering and clinical decision-making. So essentially, engineering choices and systems to give us the biggest bang for the buck for new tests. Some of this work can be done through site-specific guidelines that incorporate these biomarkers into clinical practice guidelines or clinical pathways that make it easier for clinicians to make decisions based on algorithms. There's an opportunity to tailor recommendations based on individual facility antimicrobial susceptibilities, such as from the antimyogram or formulary. There's an opportunity to provide provider feedback and comparisons, and the role for appropriate diagnostics can be facilitated by clinical decision support and informatics tools, and we are having some success in this area at this time. But what we really need is a paradigm shift. We need novel diagnostics and algorithms to aid in clinical decision-making, and these need to be incorporated into our workflows and take into account clinical decision-making. We also have a debate about early targeted versus empiric antibiotic use. We really want all of us, in the end, to improve patient outcomes and decrease adverse events. And a nice benefit would also be the downstream public health benefit of decreased antimicrobial resistance in the future and preserving the antibiotics we have. So some future directions might include more rapid and cost-effective diagnostic tools that include the host response, such as biomarkers like PCT. We really don't want to incorporate tests that are going to require a lot of training. And then in the ED, at least, when we consider point of care, or even in laboratories that have limited space, we really have to think about the footprint of the instruments as well. So with that, I will take any questions, and that is my email if anyone has any interest in reaching out after this presentation.
Thank you, Larissa, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you would like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many of your questions as we have time for. Okay, let's get started. Our first question is, how will PCT be used during flu season, especially during the current COVID-19 pandemic?
So actually, we're doing some research at our institution around PCT versus usual care with a clinical pharmacist intervention to help guide appropriate antiviral therapy for patients with influenza and reduce the inappropriate use of antimicrobials where they're not indicated. I think, with COVID, this has really impacted, our testing strategies. Right now, the main thing that people are focused on is the diagnosis of COVID, and supplemented perhaps by imaging in our sicker patients. I think we find that PCT is typically very low in COVID as in other viral infections, and so for patients that are being admitted to the hospital, a lot of our hospitalists and even ED clinicians are ordering PCT just as another adjunct to try to reduce inappropriate antimicrobial therapy.
Okay, thank you so much for that answer, Larissa. We have another question here. Does clinical pharmacology support PCT as part of antibiotic stewardship protocol?
I'm trying to understand this. Does pharmacy or clinical pharmacology?
This question just says, does clinical pharmacy support PCT as a part of that antibiotic stewardship?
Okay. Yeah, so I think, antimicrobial stewardship teams are typically comprised of an infectious diseases clinician and an ID pharmacist as well. I believe many institutions have already incorporated PCT into their antimicrobial stewardship strategies. I can say that at our institution, for adults, we do, when a patient is suspected of having sepsis, do incorporate PCT into that algorithm with a repeat PCT per standard protocol. and those algorithms are provided to the clinicians for making decisions. So at least at our institution, this has been found to be valuable and is supported by our antimicrobial stewardship team, including the pharmacists.
And what spurred your hospital's interest for PCT?
I think there had been a lot of research ongoing with PCT, particularly, our chair of pediatric emergency medicine, who's also the chair of our emergency medicine group, has done a lot of work looking at PCT in febrile infants, and that was an impetus to get it into the ED because he really wanted to use it for those febrile infants under 2 months of age. While that hasn't made it yet into the standard protocols nationally, I do think that it can be helpful in guiding whether the infant has a bacterial infection and perhaps eventually avoiding invasive tests like lumbar puncture. On our end, we really wanted to incorporate it for patients with sepsis, particularly as some of our clinicians on the wards and in the ICU like to follow the level so that they can de-escalate therapy. And so bringing that to the ED was useful. But in order for it to really impact our decision-making, we had to make it available in real time. So we now can get it under an hour, whereas previously it was not available in that fashion.
Wow, thank you so much for that answer. Great. We have another question. How has COVID-19 impacted your PCT usage, especially the stewardship and C. diff prevention in long-term COVID treatment?
So I don't have numbers for our emergency department, so I'm not sure. I think it actually probably, though, anecdotally has increased it because, again, patients with COVID-19 are often getting a PCT that's ordered by the clinician. And then I think in terms of our standard algorithms, I don't think it's impacted that since we're using, we've actually had some issues, as many hospitals, with non-ED based sepsis, so hospital onset sepsis, and we've incorporated a team of nurse practitioners that are available to respond rapidly whenever a patient meets certain criteria for potential sepsis, and that PCT algorithm is in their workflow, and they're following it pretty closely. So I believe at our institution, though I couldn't give you exact numbers, that the PCT utilization is going up.
Fantastic. Thank you, Larissa. Our next question, how do you get an ID on board, or how do you get ID on board when they feel like clinical judgment is more valuable than yet another test like PCT?
I haven't had that experience, although I do know that some of our infectious diseases colleagues have varying opinions on the value of PCT. I think a lot of it has to do with implementation, and I think the infectious diseases clinicians, particularly those involved in antimicrobial stewardship, get frustrated at the fact that the tests that are being ordered are not actually being used in the way they were intended. So I think, again, that workflow and implementation and getting the clinicians to change their behavior is the frustration on the part of infectious diseases. But I will say that a test alone without incorporating antimicrobial stewardship or other strategies is probably not going to lead to the desired outcome. So I encourage everyone who's thinking about implementing these biomarkers or other rapid diagnostic tests to think about how the clinicians will use those results and really trying to drive practice change so that you can actually see the outcomes that you want.
Makes sense. Thank you so much. Here we go. Our next question. Do you use the same cutoff procalcitonin values for infants as adults?
So I believe the cutoffs may be slightly different. I don't have them up in front of me, but we have an algorithm for adults and an algorithm for kids. And then, of course, depending if it's an LRTI or sepsis. But those are included in the lab orders so that we can see those when interpreting the results. In fact, there wasn't a lot of data, I should say, when we first started trying to use PCT for infants. There wasn't a lot of data. So, many institutions, when we talked to our pediatric ID colleagues, they had to come up with their own algorithm based on other institutions because many pediatric hospitals weren't actually really using this. So it made it a little challenging when we started this.
And you stated PCT utilization is an educational intensive process. Who's the best driver of bringing PCT to hospitals?
So I think ultimately a lot of the decision making, at least at our institution, may be that antimicrobial stewardship team. So we're very fortunate here at UC Davis. We have a very good relationship between our stewardship team that incorporates the laboratory and incorporates microbiology as well. And so often when new tests are being brought on, it's really looked at by our diagnostic committee. And then we also have a test utilization committee that makes these decisions. So it's really a multidisciplinary approach these days. That may not be true for all community hospitals or small hospitals or critical access hospitals. It is not a one-size-fits-all because in some settings, the clinicians drive the desire to bring on a new test. And in other cases, the lab sees the value. And then in still other cases, it's really a hospital administration decision.
Thank you, Larissa. Our next question here: Were days of antibiotics reduced use based upon delayed use of antibiotics, or quicker reduction of antibiotics after initiation, or both?
In the studies I presented, most of these are meta-analyses, so I think that there's some heterogeneity in what's happening. I mean, from our perspective, it's just it's stopping the antibiotics earlier than you would have.
Okay, got it. Thank you. Next question. Have you had any resistance from clinicians in PCT usage, especially with antibiotic use?
Sure. Especially in the emergency department, I think there is some concern, particularly in patients that you were thinking about discharging home, that you might not want to get a PCT because you wouldn't want to see a high result, and then it's sort of like you don't want to see what you don't think is real. And so I think it's more appropriate for patients that are being admitted to the hospital where you can send another test as recommended, in 12 to 24 hours. I think most ED clinicians wouldn't be using it for patients that are being discharged.
All right. Thank you so much again for that answer. How do you apply PCT to end-stage renal disease?
So I can't say that I have enough experience. I typically don't send PCT in those patients necessarily. I can't say I have personal experience with what to do with patients with CKD. I mean, we certainly have that issue for other tests like troponin. I think, perhaps trending over time might be one way that you can use that information.
Is a simple prick test sufficient to test PCT levels?
So I'm not familiar with the point of care tests. I don't believe that they're available here yet, and so ours is a blood draw. Okay, great. That was simple. What value does your algorithm provide for NICU? For NICU, as in neonatal intensive care? Neonatal ICU, yes. Yeah. So I believe that most of what we're doing is in the PICU, not the NICU. I'm not familiar with what our institution is doing in the NICU. I do know that they're using it in the PICU, so not in neonates as much. Okay. And is there a way to incorporate antibiotic resistance diagnosis along with host biomarkers for diagnosis? No, I certainly think that is going to be a strategy of the future. So essentially, combining an accurate diagnosis of antimicrobial resistance or the pathogens, likely through molecular techniques, plus a host biomarker or other, host biomarkers to look at the immune response, I think is absolutely critical. And that can give a more complete picture in the context of antimicrobial stewardship than simply having, for example, a diagnosis of a particular organism or just having the host response. Do you see any added value of POC-PCT assay in ICU? So we don't have any experience, again, with the POC assay. I also, we don't have much in the way of point of care in the ICU setting, so I can't really speak to that. I certainly think in the ED it could be useful, but again, we currently get our results typically in about 45 minutes, and sometimes that's faster than our nurses going and doing a POCT test, believe it or not. Mm-hmm. And what type of molecule is PCT? What induces the release in bacterial inflammation? So I'm going to defer that question, I guess, to the organizers. I can go back to my slide for a second. Okay. Looking.
And any questions can be answered at a later date, via email or.
Yeah, because I need to understand what the question is, and that's more on the physiology of PCT, and because I'm a clinician, I'm not an expert in that.
Absolutely, very understandable. Sometimes these are complicated questions to answer on the fly when you're not expecting. Do you see the capability of constant PCT measurements to monitor progress using either IR monitor or implantable monitor?
Well, I know there's a lot of interest in in remote monitoring or in wearables right now. I haven't seen anything looking at PCT as a constant marker.
Looks like we have one more question here. CAT for PCT testing and the principle of test. That's all the question. I'm not sure exactly what they mean, but maybe you do.
The TAT, so turnaround time for PCT question, I believe, is the first part of that question. So again, like I said, ideally we would like a turnaround time of less than 30 to 45 minutes. But I think you have to balance that with, if you have a POCT test, how much additional work is that, and what are you losing in terms of sensitivity or specificity? So it depends on the population, I would say. I don't know what the principle of test is either. Okay,
I wasn't sure either. But that's the last question that we have. So thank you so much for your time today, Larissa. Do you have any final comments for our audience?
Well, I just think, I'm very pleased to have been here. I certainly think there's great promise in using biomarkers to help with patient diagnosis. I know there's a lot of exciting work going on in this space right now. I do think it's important for laboratorians to collaborate with clinicians as they're thinking about bringing on some of these tests, and also really that these tests can't exist in a vacuum. We really have to think about workflow, both in the laboratory and in the clinical setting, and really incorporating it into a broader strategy of antimicrobial stewardship and improving patient outcomes.
Well, we want to thank you again, Larissa, for your time today and for your important research. We would also like to thank LabRoots and our sponsor, Thermo Fisher Scientific, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.